Hello everybody. Today we are going to discuss the question which was asked in DRNB critical care exam, that is communication in the ICU. So definition of communication, it is a two-way process of reaching an understanding or decision between the two individual or group and constitute a process of exchanging information, ideas and thought, feeling and emotion through speech, signal, writing or behavior. It could be verbal or non-verbal. Verbal communication in ICU could be impossible with certain patients due to interventions like presence of invasive airway devices or due to altered consciousness when a close family member acts as surrogate or takes the decision on patient's behalf. Communication at various levels. Patient-centered care has a five domains such as bi-psychological, bi-psychosocial, patient as person, sharing power or responsibility, therapeutic alliance, and the provider as a person. Biopsychological includes condition of the patient, therapeutic interventions, and the general hygiene and care. Patient as a person include patient's likes or dislike, habits, spiritual bend of mind, indulgence in the book, interest in the sports and politics, and so on. Sharing power and responsibility include involving patient, relatives, and decision making for care group. Therapeutic alliance is the generally limited to the patient, physician, and patient, where former is in the knowledge of the latter desire or both work for the care. Therapeutic alliance is the more specific and deeper than sharing power and responsibility. Clinician as a person describes the emotional response of the attending clinician to the patient's condition and surroundings. Now about nurse-patient communication. The ICU nurse of all care provider spends maximum time with the patient. She therefore faces the maximum challenges while communicating with the patient. Patient in the ICU has many obstacles in the communicating with the care provider as he is in completely aligned environment with unknown people around, monitors alarming and devices connected with his inability to speak and express. The fear of adverse outcome and missing the family member add to his or her frustration, and for the nurses, inability to communicate with the patient often frustrate her as well. In non-verbalizing patient, a special method called augmentative and alternative communication can be successfully utilized. Alternative communication allows patient to express through writing surface, palm tops, personal computer, and utilization of drawing, alphabet boards, and chart. Many tracheostomized patients can talk with the cuff deflated or if not ventilated with fenestrated tracheostomy tube in situ. Many long-staying patients can also express through the facial expression and lip movement, which nurse deciphers by the virtue of her constant association with patient and commitment to her responsibility of understanding patient's need. Sometimes one has to formulate short question on certain basic need of the patient and ask patient if she or he has it like, are you having pain? The patient answers through head movement and even showing where the pain is. It is necessary for nurse to understand the patient for better communication. Communicative relationship with the patient determines satisfaction and care of the latter. It is important to maintain the distance while understanding the emotional state and carefully avoid the personal relationship which nurse can inadvertently fall into. Nurses, while communicating, operate in three or five domains, as I described above, leaving third and the fourth domain, that is sharing power and responsibility and therapeutic alliance, respectively, as they think these two are physicians' responsibility, and they only work as the translator of physician to the patient and their families later on. Many times the nurses recognizes that physician withhold truth about unfavorable outcome while talking to the patient as they are afraid to tell bad news at one go and would like to family to think that there is still some hope. Later this can cause a lot of misunderstanding and trust deficit resulting in violent behavior among family members. In such a situation, nurses, while carrying forward their team role, hold brave face while explaining that patient is marginally better. Blood pressure is little higher with higher iron drops. While nurses translate everything to the physician that patient and family convey, they do not convey everything to patient and family that doctors say. The physician and the patient. Communication with the patient and the family is central to the patient management in the ICU. Most of the time, it is not possible to converse with patient beyond asking medical history, his personal detail, his likes and dislikes, his idea of outcome of medical management in the present admission, and she or he is having bit of obtunded level of consciousness. This is also not possible. Discussing about various aspects of treatment, prognosis, and outcome with patient is not possible with patient admitted to ICU for the fear of adverse impact. It would have on patient psychology that would affect his recovery process. The physician end up his visit by reassuring the patient, you will be all right, or we are making you comfortable. So communication generally happens with the family member who are presumed to have known the patient's preference and to act in the best interest of the patient. Ironically, this is one area where physicians have not performed well, and most dissatisfaction originates from the inadequate or no communication. Many families suffer from the post traumatic stress disorder TIS after the patient is discharged from the ICU or dies in the ICU. Communication skills do not necessarily improve with the experience alone. It requires training and mentoring, which is unavailable most of the time. Now, the four models of physician surrogate communication. That is directive model. The physician outlines the various modalities of the treatment and the family buys whichever they want. This is mostly one-way communication. Now about informative model, the physician informs on the disease and this thinking on the management. He allows discussion but does not discuss the patient's value system, likes and dislike, his or her preference for any particular goal of the treatment. Now the facilitative model. The physician inquires into patient's value system from the family and facilitate the family for the shared decision making. Now about collaborative model, this is like previous one, but here physician is directly into decision making process. Now, five principles of physician surrogate communication. Ask, tell, ask. Involve family in two-way communication. Ask family about their understanding of the disease and outcome and make them comfortable with you. Listen to them carefully and make them believe during the course of communication that you had been attentive when they were briefing. This builds trust between the family and the physician. Physician could ask permission from family before giving information. This gives the family confidence and makes all of them listen to the physician. Tell them about the present state and the treatment outline and possibly outcome without getting into too many details like pathophysiology of the disease, outcome quoting literature on the subject. Use simple language without medical jargon, which they may not understand much. At the end, ask them what they have understood to ensure that your communication is effective. You then encourage them to ask questions which also confirm that you had an effective communication. Now tell me more. If communication at times goes off the desired course, stop and ask the family whether they have understood so far explained, or if not, they have to be reassured and help to tell more about their emotion. The physician then correlates the information he wants to give with their emotion and again give them information while trying to build their confidence. Use reflection rather than the question. Reflections are the repetition of the surrogate word and phrases or the implied meaning of his or her expression. Like, did you say how long he would talk to become normal? or deciphering surrogate background belief as so you are not convinced that we should do a tracheostomy, or not reflecting as you are not convinced that we should do tracheostomy. uh, that is complex reflection. In the later reflection there is a question mark at the end of same expression as a former whose immediate response is yes or no. In the former reflection there is a silence, and the surrogate will take some time to think and ask the physician some related question, which the latter will clarify. This allows surrogate to have control over communication and therefore satisfaction, while physician will be able to get consent for tracheostomy with all probability. Now the skills for responding to emotion. ICU patient could go through the life-threatening moment, often culminating into the death. Such an event could arouse emotions of varying degree, and relatives could exhibit frustration and anger. In such an emotional stress, the surrogate may not even register what physician in that time. Physician, instead of waiting for decision for them, should show empathy on them and give them time to grieve. This that acquires trust and confidence for the physician. With this approach, the relative bring out many memories relating to these emotions, and physician get to know many more deeper aspects of his or her personality. That helps in taking decision befitting to his value system. Assess the patient's information, decision making, and coping style. As per psychologists, there are two types of coping style: monitors and the blunters. Those who are the problem focused would like to plan ahead need of information, and they are called monitors. Those who do not go beyond the emission are called blunters. They avoid lot of information and want other to take decision. Some of the blunters after persuasions can become monitor, and it may not be the advisable to give a lot information to these people. Majority of the people, however, are mixtures of monitors and blunters. Now the barriers to the good communication. Pathophysiology discourse. Medical detail useless unless asked should not be shared. Focusing physician view and not giving time to decide. Not finding out patient's values and beliefs. Premature reassurance that patient will become better might make the physician position embarrassing later. Not allowing time to grieve and forcing decision. Now about family meeting. Fixing a time and notifying well in advance to all stakeholders. Who should be present: primary physician, intensivist, other attending physician, nurse, social worker, administrative representative, and surrogate. Select a place with good ambience. Facilitate introduction with each member. Spell out purpose and agenda of the meeting. Assess what family knows. Confirm broadly if their knowledge is correct, and after pause, quietly disagree if not correct. Explain the patient's overall big picture and what is being done. Ask the family if they have questions. Ask them his preference and value system. Propose goal of the care after negotiating with the family. Summarize document and take signature of everyone present. Mention the time for the next meeting. Now about breaking bad news. Many complained that doctor was too blunt and abrupt in informing bad news. When bad news is given properly, it brings about the satisfaction and trust. The following procedure should be followed, that is spikes. S is setup. Decide what do you want to speak. Make sure who all you want to speak, and attending nurse and social worker should be the part of your team. Introduce yourself, your team, and know the relationship of all family members. Have some tissues to wipe out tears. Get close to the nearest relative and make eye contact. Now about perception. Find out family's perception first, as they may have been given some information before. If their perception is already bad, your information will only reinforce. It but if it is not so bad, your information will upset them, and maybe some may break down. Now the next is invitation. Ask them how much they want to know. There may be differing answer as some need overall condition and some need details. Now about knowledge, one can initiate start off with warning statement like I am afraid things are not going well for us. Give the big picture in very common man's language, avoiding medical jargon. If you are going against their perception, stay quiet for few moments so that family gets time to assimilate their information. Then slowly break the balance. Then empathize. Allow their emotion to flow and use few empathetic words or phrases to make them appreciate that you are with them in their moment of a grief. Once they are in position to listen, ask if they have questions. Summarize and strategize. Once they are again in receiving state, ask them if you can proceed with the plan of management from now. If they are still not in good mood, go back to empathize them. Now about withholding, withdrawing and end of life care. Requirements are physicians should have clear knowledge of legal provision like level of evidence of patient preference on the issue and authorization of the surrogacy. Correctness of the decision to withhold and withdraw life sustaining treatment. Total commitment to maintain comfort and dignity of the patient. Planning out the process by coordinating with the treating team who should be present in the meeting, patient's family, priest, and the legal surrogate if any. Decision should focus on basis of foregoing life sustaining treatment, patient preference, value system, and goal. Difficult question and surrogate would be asking. The sense of guilt that surrogate would be having has to be negated by saying that he or she is dying not because of the decision to withhold and withdraw, but because of the irreversibility of his parents' illness. Thank you, guys.